Good evening and welcome to the ASPN PSPS webinar series on cancer pain management in the era of COVID-19. Thank you so much for joining us tonight. The webinar will begin promptly in 1 minute to give some additional attendees time to log on. Again, thank you for joining us tonight. We will begin in 1 minute. Good evening, everyone, and welcome to the ASPN PSPS webinar, Cancer Pain Management in the Era of COVID-19. Thank you so much for joining us tonight. The webinar is now beginning. I would like to introduce our moderators this evening, Drs. Timothy Deer and Dr. Krishnan Chakravarthy. Gentlemen, take it away.
Well, thank you very much, and thank you all for joining us tonight. Cancer pain is certainly a very unique area of medicine, and at this time of COVID, it's been very unique as well. So tonight, in the next hour, and we'll be right on time for you, we have a great panel for you to discuss several aspects of cancer pain, for both today's times and for the future. And joining with me tonight is my dear friend, Krishnan Chakravarthy. Krishnan, you want to introduce our panel? Krishnan, you're on mute, my friend.
There we go.
There you go.
Thanks. So we've been kind of moderating the last 6 of the different sessions around COVID, and this one's actually a really a special one because I think it's understated how important and in terms of just patients that are given in that arena of cancer pain and the importance of trying to get good care to them. I think, you know, one of our chants that I had with spending some time with Lisa Stearns, you really get to see the empathy and the emotion that goes into taking care of these really sick patients. So one of the pleasures I have is to introduce this group of folks that have been really thought leaders that have really set the standard and benchmark for how to treat these patients and have come around to creating a lot of the algorithms that we think about all across the country. Dr. Gulati, who needs no introduction, is out of New York, has really been heavily spending a lot of his career developing a lot of the treatments, a lot of the thought process around how to triage these patients, how to take care of them in an effective way. And Don, of course, is another person who needs no introduction out in Hawaii. She runs a really successful private practice. And so they're going to really start with really talking about opioid management and also what to do in this new current climate of COVID-19. So Amit and Don, take it away.
Thank you, Dr. Deer and Dr. Chakravarthy. I guess I just wanted to spend a couple minutes of what's been happening at Sloan Kettering. Then I'll give it over to Dr. Sparks here, and she can continue from there. You know, obviously for our cancer pain patients, we can't not deliver care. It's very tricky. Just in cancer in general, if we delay treatments from 30 days, 60 days, we can change the staging of cancer. So it's a tricky environment where we know that if a patient gets the virus, they may be putting themselves lives in risk. At the same time, if we prevent getting treatment, the same situation happens. So we know that we have to treat these patients. So you know, we didn't necessarily shut down our pain clinics. We just triaged our patients accordingly. You know, obviously telemedicine really took hold in the last 2 months, and we were already beginning the transition to telemedicine because of some regional reasons in our practice. And managing opioids became a challenge. And part of the management is that we know that oncology patients have the same rates of abuse, same rates of tolerance as some of the other populations in chronic pain, but you can't manage them accordingly. You can't do your urine toxicity screens like you would in a random fashion. So some of these things are still being worked out in our hospital system, trying to figure out how can we still manage opioid management safely, and then how can we implement some of the things that we implemented before, which was to mitigate or to reduce reliance on opioids in general. So some of our interventional strategies, some of our intrathecal drug delivery systems were being delayed because we couldn't have surgery, so that therefore patients are on opioids a lot longer. They're exposed to some of these opioids that can be immunosuppressive in nature. And so a lot of decisions had to go through and what things can we provide in a short term to get these patients through their pain crisis, and at the same time, what interventional strategies we can still provide our patients so we can mitigate opioids.
Yeah, before you go, Dr. Sparks, I'd like to ask Ahmed a question. So you mentioned immunosuppressant, and you said certain doses of opioids that would cause immunosuppression. What are those doses? I can't seem to figure that out. I've asked that from some other folks recently. What dose do you worry about, and when would you take someone off an opioid?
When it comes to immunosuppression and metastatic disease, I think you look at the animal models that are suggesting morphine and fentanyl may have those kind of effects where natural killer cell cytotoxicity and lymphoproliferative and those cells will be decreased as a result of morphine and fentanyl. I'm not sure it's dose related in the human model, and a lot of these things are controversial when it comes to human models. There's some data for morphine maybe increasing the risk of community-acquired pneumonias in the elderly population. So what I tell people when it comes to opioid management is an oncology is a very structured discipline. So their research is very well thought out, and these kind of cofactors for influencing disease survival and remission rates are very stringent. And morphine is a pain medication that's commonly used. It's hard to see morphine having a real effect on survival curves in oncologic disease. However, from animal models, we know that oxycodone and hydromorphone tend not to have these effects. Buprenorphine and tramadol tend not to have these effects. So instead of thinking about dosing, which is very difficult to find in a human model, what I suggest usually to our patients is consider oxycodone and hydromorphone as your first-line strong opioid. Consider tramadol and buprenorphine as some of the medications you can do first line for post-operative pain and some other strategies, and then use morphine and fentanyl as your last line opioid, even perhaps behind methadone, which tends to have less effect in the animal model.
Wow, that's extremely helpful. Dr. Sparks, your thoughts on these issues?
Yeah, no, I agree with Dr. Galati, and thanks for all of that information. That was great. Basically, when patients have cancer and then we're in a crisis like we are now in this world pandemic, and maybe they're having an intrathecal pump, they're also going through a lot of psychosocial issues as well too. So if I did a pump fill during this whole thing, which I had to, the patient was living alone, she was elderly, she was having cancer, and all of these things, and I gave her those options as well too, to say, we're going to do this pump fill, but these are the medications that if we were going to think about like adding any additional medications for pain relief in addition to the pump, if the pump isn't being efficient, that we would not want to use morphine, we would not want to use fentanyl. And also the idea of patients, I'm a very huggy person, and most of you probably know that, and patients like that, and especially when we're going through something like this where there's like no socialization, I feel like the patients really strive for that, and I'm just curious about how everyone else too is going to kind of introduce that socialization back to their practice.
Yeah, so Dr. Chakravarthy, what do you think of the hugging?
Yeah,
missing the social interaction?
I think there's so much to say for how important that is in terms of building rapport with patients. And I think one part of that is the assumptions are that if this, hopefully within the next 3 to 4 months, that we see a reduction, we're going to get back to some semblance of what we had before. But one thing I've heard through a lot of webinars now is that telemedicine is here to stay. And I think what's unique to a lot of cancer pain management is a lot of the multidisciplinary aspects of different services. So this is actually a question to Dr. Galati. Do you see there a benefit to some extent of transitioning to this virtual forum as being able to deliver better care across multiple kind of departments with oncology and pain management working together, maybe triaging and actually providing better care because of it?
Excellent point. So when people ask us how we manage our cancer patients in our hospital, one of the questions I always get is, how can you get your oncologist to send you referrals? And my take-home message has always been, you have to go to the oncologist and be a part of their team. And so we've had the opportunity at our hospital to be part of different tumor boards for years. spine tumor board, bone tumor board, various oncologic tumor boards that have their surgical disciplines, their radiation oncology disciplines, and then now have a pain service associated with that. With telemedicine, what we've seen quickly is that they have transitioned their tumor boards to an online format, Zoom or a webinar or some form. And so now it's actually much easier for us to join these webinars, introduce ourselves, and be available for consultations. And if you're in a place where maybe an oncologist may be far away, you can provide that pain care through telemedicine that day now, which is what really cancer patients need. When oncologists think that a patient needs pain care, they don't want their patient to wait 4 weeks or 6 weeks or 8 weeks for a new visit. They would like that patient to be seen that day. So now the point of care has changed. The ability of a pain physician, and that's a group of us, to be able to offer oncologists immediate access to a pain physician, and then we can triage to interventions will dramatically improve if we take advantage of this moment. And that's what we've already done at Sloan Kettering, where we've seen 2 tumor boards transition to a webinar format, and now I'm a part of those webinars. It's easier to get those consultations that perhaps may have taken weeks. You can provide that care the same day, which is what a patient truly wants and what an oncologist truly wants to have for their patient.
No, I mean, I think that's so amazing. It improves the care. Dr. Sparks, let me ask you another question about the social part you brought up. I think it's so important. You're so good at it. I had a patient last week, and he actually was sent to me by his primary care specialist, but he was in the waiting room of his oncologist doing telemedicine with me on his phone. And he was going to get a CT scan of his liver, and he started getting teary-eyed, and I could tell he was very anxious. What are your tips to those attending this webinar? What are your tips, since you can't hug them and you can't touch them, what can you do on the phone to give them the same sense of caring? What's your advice?
Well, I think that in general, it's kind of just the more thoughtful listening and just asking a lot of open-ended questions. And there's been quite a few patients who said that they wish that they could hug, and just allowing them to have that moment. I've done air hugs, like they're and just let them know that we're gonna get back to this. We're all gonna get through this. This era of COVID-19 will probably be forever, written about in textbooks when we're all gone. And this, I hope, I really do hope that this will bring like the humanism back to medicine, because Dr. Gladdy's right. Like, you can actually just go onto some of these platforms and add a patient and see him right away. And it gives you like this greater flexibility that I don't think that we ever had before, because our lives were pretty rushed and stressed, and we had full schedules, and we just had to go from one room to the next. And this might give us the availability that we didn't once have before. So that along with bringing the humanism back to it, and just letting them know that this too shall pass.
I have to say that's an amazing point, because you hear so often patients are just scared to even come in to get a procedure or to come to clinic. And you think about how these things can make sense in all different settings, not just in cancer pain. So I think that I really appreciate that part of it. I think that's something we can all take home and say, okay, that's something we can implement. So, yeah.
Yeah, and I think it's really.
Let me ask you one more question, both of you, before I don't want to leave your panel without this question. I think it's very important, and I'm going to start with you. And the question is this: we have a lot of fellows attending this webinar, and we have a lot of young people who just really have started treating cancer patients. In fact, I left my probable field of cardiac anesthesia to go into pain because of a cancer patient I was able to treat with an epidural at end of life. So it changed me and made me become a pain physician. What would be the one word of advice both of you would give to the younger doctors on this webinar about this issue? We're talking about communication and opioids and telemedicine with cancer patients. What have you learned in this pandemic for both of you that you'd like to pass along as a word of wisdom to these younger folks?
What I've realized is really emphasizing that even with a situation such as a pandemic, you really can't lessen your compassion for the situation that your patients are in. They're in a worse situation now. Now they can't get their treatment they want, and now they get scared of getting treatment because of the virus. And we're in an area where people don't want to come into the hospital and get treatment. And so you really have to put yourself in their shoes and be much more lenient with some of these things of opioids and decision making on whether we should be using a non-opioid when an opioid may be the best course of action. For oncology patient, the data has always been opioids have been very, very helpful for our pain patients, treating a patient's pain. And we don't want to lose that because we have so many other options. In this situation, keep in mind that the opioid still is beneficial, and some of these things that have come out in our field, which have really pendulum has swung the other way, doesn't really apply to some of our cancer patients. Keep that in mind.
So if I have to come up with one word, I guess my one word is going to be tenacity. And I think that we all have that, and we've all proven that. And if you're a fellow, you know you're still using it and trying to find a job in this time and everything else. But as related to cancer patients, you do, as Dr. Galati said, want to have compassion, but also passionate perseverance just to help them to get to that next level. Because even though we don't know if our lives will ever go back to normal, if there'll be a new normal, they don't know how much longer their lives are going to last. And you really want to be there for them when they need them.
Inspirational. Yeah, very inspirational words.
Great discussion for both of you.
Yeah.
Thank you so much.
Thank you.
There might be some questions at the end if we have time. So hang around if you can. Thank you so much. Great words of wisdom from both of you.
Yeah.
Good to see everybody.
Bye-bye. Krishnan, you want to discuss our next panel and introduce our colleagues?
Kind of our next panel, we wanted to give the folks today a perspective, not just from a individual practice, but kind of a larger health system. Dr. Greider also needs no introduction, has been really instrumental in working on the physician administrative part of it, and he's really carved out the latter part of his career, really looking at adoption of big policies, et cetera, across health systems. And Dr. Kalia also around working in Rochester and upstate New York has done a lot of stuff. So want to really give our folks a perspective on, the challenges that health systems are facing, especially specific to cancer pain patients, and what you guys would give advice for folks that are listening today. So Dr. Greider.
Thank you, Krishnan. So in the Midwest, a lot of the issues that we're seeing are we haven't actually had a surge of COVID patients, yet we have this shutdown that has paralyzed our healthcare systems. And the most vulnerable of those patients are the cancer patients. It's an interesting phenomenon across the country that people are seeing, that people getting access for stroke and cardiac events are down 60, 70%, but yet we've been able to maintain cancer pain and cancer management. And so that's the one area of our health system that hasn't slowed down at all, because the urgency around those treatments are pretty significant, obviously. So the real issue is, how do you safely care for those folks with immunosuppression, and how do you care for those folks that are oftentimes their immune systems are at their lowest during that time? And so that's been a real challenge, to set up testing to make sure that the healthcare workers are safe, and that the other patients that are surrounding them are safe as well. The third piece of it is, in the midst of trying to manage chemotherapy and infusion and all of those things, it's the human piece of it is actually returning in some really interesting ways. So the telemedicine piece, you guys touched on it, but this pause in the urgency and the intensity of volume has really, I've heard patient after patient after patient say, you know what, this is the first time I felt like people have actually sat and listened to me. And so it's that ability to step back from the pace of practice that is really interesting. And I know that we're going to go back to high volume practices, but I just hope that in some way we can figure out how to balance out that truly interactive piece that also allows us to see large volumes of people and take care of large numbers of people. So that's some of the things that we're seeing in our health system. Specific to the pain management piece, is really continuing to try to get patients that are recovering, but who have those neuropathic and mechanical pain issues in for our neuromodulation therapies. And that's starting to open up now that we're beyond the restrictions and the surge issues.
Jay, let me ask you one quick follow-up before we get to Hemant about what you just said. For those who don't know, Dr. Greider runs a large portion of the Kentucky system, and he knows it better than anyone. We've had 2 small hospitals in West Virginia close in the last month. because they didn't have any COVID patients, but yet they couldn't do any care. And they actually went bankrupt and closed down Fairmont, West Virginia, Williamson, West Virginia. What about those doctors on this webinar in small hospitals? Is there going to be federal funding to keep those facilities open? I mean, what's your I know you have a lot of contacts in the area of funding for hospitals.
So, it's really unclear. It has to do some with the political environment as well. And so whenever we get into a situation where the entire health system is on life support, I was actually doing an interview just this past week that said it's ironic that in the middle of a health crisis and a pandemic, we also have a financial crisis in our health system, because those small hospitals, Tim, that you referenced, those are low margin hospitals. They're working on 2 and 3% margins. Sometimes 2 or 3 million is all they have as a margin at all, and that's really no margin whenever you stop and think about it. So, is the federal government's solution going to be forced mergers with larger institutions that are stable, like we saw with the banking system in 2008? Or are they going to try to preserve the autonomy of those smaller systems? Well, I think maybe they wanted the autonomy of those smaller systems that were struggling to begin with to be assessed and evaluated, just like they did stress tests on the bank. I'm not hearing that yet, but I wouldn't be surprised if there's not some sort of similar concepting that's done nationally. We're already starting to hear rumblings of hospital mergers here in Kentucky and in Tennessee. And so those larger systems are maybe asked to absorb some of those smaller systems. We saw medical practices that went into a real situation, and pain practices. We started managing quite a few pumps that were just almost abandoned because literally within a week the finances were so upside down those practitioners couldn't care for their patients.
Yeah, thank you, Jay. That's that well frames the situation with practices in hospitals and centers. So that sets a tone for our next colleague, Hemant. What's your thoughts on these issues with the pandemic and cancer pain treatment?
Yeah, thank you, Dr. Deer and Dr. Chakravarthy for having me on this panel. So here in upstate New York, when the COVID-19 pandemic started, we were grappling with some tough decisions. It was uncharted waters, and we really had to make some tough decisions, especially in the cancer pain patients. Most of the societies did come up with almost like a prescriptive instructions on how to tier the procedures for general pain patients. But as far as cancer patients were concerned, we didn't have any specific guidance from anywhere. So we actually had to come up with our own kind of a system how to address the issues of cancer patients, whether they have active cancer, whether they are at the end of life, whether they are cancer survivors. So that allowed us to stratify the risk of cancer patients based on their disease process and where they are exactly, and which allowed us to offer treatments to them almost in a stratified manner. We sometimes had to rethink our strategies. We know that the usage of corticosteroids in this pandemic kind of exposes these patients to unnecessary risk and decrease their immune system even further. So we really had to rethink our strategies how to help these patients. I did more chemical neurolytic procedures in the last 5 weeks as compared to I did in the entire year yesterday. Similarly, I also saw an opportunity to kind of introduce some of the advanced treatment options like neuro stimulation or neuromodulation early on, especially targeting the peripheral nerves, which are very low risk procedures, which can be done at bedside, in the hospital, or as an outpatient, depending upon which health system you're practicing in. And we were able to offer some of the evidence-based treatments and some of the treatments which are almost becoming extinct. And we were able to improve our patients' not only pain, but also their function and quality of life. So this pandemic actually taught us a lot on how to take care of our cancer patients.
Very good.
Interesting. I have an interesting question for both of you, actually. And going along the lines of, we're at an interesting time, let's say, for example, telemedicine. You've talked on multiple panels now of the benefits. And a lot of folks across the country are saying, if we're implementing this, how do we get the message across to CMS of its value to appropriately reimburse physicians to incorporate this kind of modality in their treatment platform? And the kind of the follow on to that is, ASPN has taken a huge leadership in that part of it. And I see this kind of being truly a cross society effort. And is it something that you think, Dr. Greider, specifically when you're looking at the entire Kentucky health system, is that where it needs to be advocated for, or do you really see this coming at a grassroots level?
Well, absolutely. I think the biggest thing is if you wanted to prevent the adoption of telehealth, CMS couldn't have done a much better job with the regulations that they had previously. They were so restricted that, I mean, who could have done it? It was a person who was not in a metropolitan area within a certain, who could follow all the guidelines. So what the heck would I ever do that for? So making sure that we keep the restrictions relaxed. And the other thing that we find is that whatever the financial incentive is, people tend to follow that. And so you're absolutely right, Krishnan. They need to make sure that the funding is there to allow people to continue to embrace that technology. Otherwise, it will have been a big experiment in teasing our patients with real convenience and access, and then pulling the rug back from them, creating hardship on practices, because patients will be demanding the ease of that, but it will be financially difficult to actually provide it. And you don't want to say, I can't provide this because it puts me at odds with my ability to stay in business. So the lobbying is going to be key on this. But I think CMS is listening, and they also see this as a low-cost alternative to drive things in the way that they want to go, actually.
Let me ask you, before you answer this, I want to ask Dr. Clay, I want to ask you a more specific question based on what Jada said. How do we examine? So let's say they do keep the guidelines relaxed, because I think if reimbursement drops, people will quit using it like that. It'll be gone. But let's say they do relax the guidelines and we can continue to use it. In this cancer population, how do you do a good examination by telehealth? You got the video up there, and you get the daughter trying to point the video at the back or wherever. How do you examine these people? Is that going to be optimal or adequate going forward for us to do a good job in the cancer population?
So I think that's a great point, Tim. I think that's what I would like to go back to Dr. Gulati's point. I think telemedicine is here to stay. We'll have to exploit telemedicine and incorporate it in our paradigms, where we can introduce this to improve not only our efficiency, but also patient outcomes effectively. So as far as a perfect example of incorporating a telemedicine visit is concerned, collaborating with our oncologist colleagues, offering a initial evaluation early on, and then maybe offering treatment specific, almost on a spoken hub model platform, where a plan is made in the virtual world, but the plan is followed in the physical world in individual practices as far as the injection therapies are concerned. So some of the evaluations, no doubt, will require physical examination, but you can definitely, as a team, evaluate a patient, get input from your oncologist, maybe have a physical therapist on board, maybe have an occupational therapist, your palliative care team first, a psychologist, and a social worker all together. And patients are booked for maybe a 2-hour appointment, and a common plan is made with all the specialists, and then patients can go physically to these nodal points to get these treatments on. I think that's where a good thought out plan is going to be really helpful.
I love that. That's a great solution. Last question for you guys. I think it's an important one. And then Krishnan, I may have a follow-up question. If you're writing a textbook going back 10 years from now, and you say, what did we learn in this topic of, rethinking therapies right now during this pandemic with end-of-life cancer patients and survivors of cancer? what would you say we learned? We're not through this yet, Jay, so we may still have more to learn. But what are we going to learn from this that's going to change the way things are done 10 years from now if another pandemic occurs?
Well, and that actually goes back to what Dr. Kalia was saying a bit. For us, we've seen that, the old paradigm of you get in the car and you go and you drive 2 hours or an hour and a half to see the pain provider, and you're already in pain. You get there, you wait in the waiting room. A lot of the visits can be contentious just because it's difficult for our patients to get there. And then you talk to them about a theoretical thing like a spinal cord stimulator or a pump that's going to require a trial on a different day and all these many things. And people sometimes feel like, what can you do for me today? And I think that's the value of what we've learned here is I can zoom into your living room where you are in the comfort of your home. You've wasted no time and talk to you about neuromodulation therapies that then allow you to consider it so that whenever you come up here, you're having a learned discussion rather than hearing it for the first time and then going back and rethinking it. It really has, we've actually gotten into almost a neuromodulation second opinion kind of clinic where people are calling and going, here's what my doctor was thinking about, what do you suggest? And, and some of it is around branding of different therapies, this brand is what they use. What do you think about that? And, you could give a balanced view of that. But I think that's going to be the thing that maybe is written about is that, it's the taking of therapies into patients' home. The other thing that's really fascinating is to see how they live. It's really interesting to be talking to your patient that you've been counseling about smoking, and they smoke 3 while you're in your 15-minute visit. You're like, at the end, by the way, you aren't really sticking with that non-smoking plan that we had. So if we could just smoke 2 in 10 minutes, that would be great. So, anyway.
Right. So, yeah. Go ahead, Emma.
Oh, no, I completely agree with Dr. Brewer. Yeah.
So one final question before we move on. We hear a lot about the challenges of conservation of hospital resources, specifically to PPEs. Do you think your strategy on appropriate PPE changes between cancer patients versus regular patients that are being triaged, given that they may or may not be higher risk for immunosuppression? And does that have any impact in the larger kind of health system? How do you justify, not justify it? Any comments on that?
So one of the things which we did in our center, we actually started testing all patients for COVID-19 before doing any procedure. Specifically, cancer patients fell into that category. It did impact our usage of PPE as well, because if we have ruled them out for active COVID infection, then we don't have to necessarily comply with all the mitigation strategies. Social distancing strategies, yes, but some of the mitigation strategies were kind of lenient. So I think those specific decisions helped us to take care of our cancer patients much more effectively and in a timely manner, and address our PPE, issues at the system level in our hospital.
Great idea. I love that.
Yeah.
I think where practices have gotten in trouble or hospitals have gotten in trouble is where they're restricting PPE and staff don't feel safe. And I think we need to keep the frontline healthcare workers as front of mind that are out there and really at risk. And so those strategies that seem like they're risking exposure, that's where hospital systems have gotten sort of sideways with their frontline workers is that lack of concern that comes across. And it's just in conservation of equipment, but it also is, I think the liberalization of that is important as much as possible.
Important, yeah. Yep.
No, I think that was a great panel, guys. We appreciate you and thank you so much. I think your insights are very valuable, and I learned a lot from both of you. So thank you again, and we look forward to hearing more from you as we go forward the next few months here. Our last panel, and we're going to stay right on time for you guys at home. We're going to look at the management of current cancer patients with pumps, because it's been a real issue, and how do you get them in? How do you fill them? Do you fill them at home? What's the risk of putting a pump in? Do you do a trial? There's so many questions. So we'll start with our colleagues here. Dawood, your thoughts on this issue to start off with you.
Yeah, I mean, I think I echo, first of all, thank you for everyone tuning in. It's just amazing, that we have this many people continuing to tune into our webinars with all the other webinars going out there. But I think this is a topic that is, to the people that really are interested in this field, they're very passionate about it. Our kind of strategy with these patients with pumps and cancer pain in general is like, we never stop seeing them. We really kind of never close the doors on them. I'm pretty passionate about interrupting care for these people. Even interrupting care for 1 month with someone with stage 4 cancer is a huge deal, when people have life expectancy of weeks to months. So we never really stop taking care of those patients. But again, we are still grappled with maybe our most vulnerable patients as well. So we had to kind of take the appropriate precautions to not put them at undue risk. So it was, every patient was kind of taken care of, or it continues to be taken care of on a case-by-case basis. We've never really created any type of algorithm or spreadsheet on how to deal with our cancer patients. We really just deal with them on a case-by-case basis. This patient has this type of pain, he's got a compression fracture, he needs to be treated. This patient has, end-stage cancer and the pain's not controlled. We really need to move forward with the intrathecal pump and take the appropriate steps and reactions. But I'm going to kind of give it up to Anjum. Anjum is someone I respect, who does more pumps than anyone I know on the planet. So I'd be interested to hear what his strategy's been as far as how to manage these patients. He's doing a lot of unique things, I think, with home infusion systems and telemedicine as well.
Thank you, Dawood, and thank you, Dr. Deere and Dr. Chakravarthy, for having me on as a panelist. A lot of our cancer patients during this time, they need to stay at home. They are one of the most at-risk populations for getting sick if they're exposed. And this is during this time and after everything opens up. Again, a lot of them are immunosuppressed, a lot of them are elderly. They're the one population that doesn't need to be out and about. What we've done is, there are many home infusion companies out there, AIS, Basic Home Infusion, Pentec. We've been using AIS as kind of a way to continue to manage these patients. And we have a nurse that goes out to the patient's home to refill them, to reprogram them. There's also have a call center, which they check on these patients. So we're able to check on these patients probably 2 or 3 times a week. Make changes to their pump if needed, get them refilled. So there's really no interruption of care, and these patients really feel like they're taken care of.
Angela, let me ask you a follow-up question on that. So I saw a patient on telehealth last week that had metastatic lung cancer, and he was pretty miserable, and he was being sent to me because he was on fentanyl and he was on a morphine. His morphine equivalent was like 400. He was on gabapentin, and I got a call from his primary care specialist. He said, we just can't control it with the oncologist. And he said, can you talk to him about a pump? I see no reason to do a trial on that gentleman. I think we should probably just go to a pump. Do you see a reason to do a trial? Am I wrong in that situation, or what do you think in the current setting? I hate to bring him in twice and put him through that system twice.
Right, and I completely agree with that. For all of our cancer patients, what we've done is we've skipped a trial. These are the only patients which I don't require a psychological evaluation. These are the only patients with which they can continue their oral opioids. We basically go straight to implant. I think Dr. Galati said these are the patients you want to get in immediately. You not only want to get them in immediately to evaluate them or do a telemedicine visit immediately, but you want to get them a pump immediately to get their pain under control. So we kind of fast track these patients straight to an implant. We appeal to the insurance companies, and we've really had no denials, because you really don't want to be the person on the other line that says no to a cancer patient. So we fast track these patients, get a pump, and as we're titrating up their pump, I voluntarily ask them to wean off their oral opioids. And as you said, if their morphine equivalents are high, I institute a PTC or PTM and tell them to use that rather than taking their breakthrough pill. So we try to get them to just use their pump and minimize orals if needed.
So this is actually for both Dr. Syed and Dr. Bucks. Both of you guys have been very fortunate to able to deliver care in this new COVID-19 climate. And there's portions of this country where entire private practices are going under because they're not able to sustain their practices. Are you going to see a real uptick in the number of management of pumps that are other clinicians, patients that are coming to you? And has that changed your thought process or strategy around that? Or any suggestions for folks in terms of partnering with clinicians like yourself on the early onset if they're having that kind of difficulty that they are foreseeing with their practice and reopening?
I think what we've seen is a lot of practices around the state. I know I've talked to Dr. Grider. There have been some practices that have shut down during this period, and they're not able to manage pumps. They've kind of left their pumps to one of these home infusion companies to manage, or they've referred them out to either Dr. Grider at the University of Kentucky or us. So we certainly have seen this. The problem is you're managing somebody else's pump, and that's always an issue when you kind of inherit a pump from somebody else. You kind of have to tweak it a little bit to make it what's appropriate for your own practice. But we certainly have seen this. I think that it's, what we're probably going to see in the future are kind of centers of excellence for pump therapy, where you have a lot of these centers that manage a lot of pumps. They have the infrastructure to manage pumps, and they have the staff to manage pumps. And we'll probably see a lot of these pump places pop up where if you have, a few number of pumps, it's probably easier to give it to somebody else that manages more.
Now, let me follow up on that to Dawood, because Dr. Bucks, you give a great answer, and I think a center of excellence wouldn't be a bad model. Actually, it might be a great model for us all. But Dawood, what about, right now there's 2 manufacturers in the United States, and let's say you're in a center and the one company doesn't have a representative right now who can cover pumps, and the other company doesn't have enough pumps at the moment. There's a shortage of pumps, as you may know. So what can you do for that lung cancer patient I talked about who had multiple metastatic disease? What about tunneled catheters? What's other things you could do if you can't go to a permanent pump?
Yeah, I mean, I think you bring up a great point. We're kind of faced with a little bit of a dilemma here with our vendors for these products. There could be an access issue kind of moving forward in the short term. Hopefully, it's not a long-term issue, but I think we still are, as interventionalists, have multiple tools at our disposal. I think that's when you have to kind of put your thinking cap on and think about, Hemnet mentioned Neurolytic Blockade. I've done quite a few of those. I've done actually probably more spinal tumor ablations in the last 4 to 5 weeks than I typically do, and that's because trying to avoid general anesthetic and pump placement in the initial phase was one of our biggest concerns. That's actually worked out very well. Tunneled catheters, I think, are another really good option and idea. The issue we're kind of limited with here is that we don't really have the outpatient nursing services that can really manage those patients effectively. So that's been kind of a rate limiting step for us over the last few years. But I think those are definitely all really good ideas. But short-term medication management in these patients is also always an option. We try to avoid those in our patients and try to decrease their reliance on systemic opioids, because we feel that they tend to do worse, and the data kind of shows that their survival rates go down.
Excellent.
Krishnan, you have another question for him before I go to the last question for them?
Well, one more actually. We at UCSD have 5 fellows, and it's interesting. We've seen almost a significant downtrend in the amount of training around managing as well as putting in new pumps, because you've seen an uptick of a lot of these other interventional therapies like PNS, SES to manage cancer pain. Dawood mentioned a few that he's been leading. I'm really captivated by the comment on developing centers of excellence for this. Is this something, do you think, I can tell you most likely best case scenario, everything goes back to normal in the next couple of months, but let's assume this extends out over 18 to 24 months. Should there be another reinvigoration at the fellow level to start focusing on understanding these management and trying to develop a core curriculum around what is it a center of excellence would really require? And especially kind of Dawood coming from the aspect of leading a society, I think this plays into some emphasis on the educational for the latter half of fellows. Do you think this is an important part to really consider for training programs?
Yeah, and I can start out this. I know Anjem has some really strong opinions about this as well, but we've been teaching fellows and some of us in fellowships, but all of us kind of teaching them in courses and in society meetings. And pretty much every fellow, when you query them, they all say they want to do stimulators, but when you ask, show of hands, how many of you guys plan to do pumps, a lot of hands drop off every time. And I try to teach the fellows that we have that you really want to not just be a one-trick pony. There's going to be patients that really do require intrathecal therapy, and I think probably there is some baseline infrastructure that practices need, but I think a lot of it is just a lack of good training during the fellowship era when they come through and they're not exposed to them, and it becomes kind of an intimidating thing to manage a pump. Anjem, if any, he's an example I use for a lot of people. They say, well, I'm a solo practitioner, how can I manage pumps? Well, there's a guy down in Kentucky that manages thousands of pumps, and he's been by himself for several years, so if he can do it, pretty much anyone can do it. And I'll let Anjem kind of chime in.
Well, and Dawood's right. I mean, if you do pump therapy correctly, they don't hassle you. Your patients don't call you. They come in for their refills and they're doing well. I get more calls from the patients on prescriptions than I do from my pump patients. But going back to your question, I think it's very important to have education around pump therapy. I think patients do very well with it. As far as longevity of therapy, if I ask any of my pump patients, they come in, they say, I'm not doing well. It's a reversible therapy. I always offer, I can turn it off, and none of them want me to turn it off. They all say, oh, no, don't take my pump away. But patients do very well with it. And I think it's important to have education around the during fellowship on pump therapy.
I have two questions for you guys. Both are the first one's very quick. The second one's very cerebral. So first one is, in my practice, I've almost shifted. When Jason Pope and I were working together, Jason and I did quite a bit of research on ziconotide. And I've almost shifted 95% of my pumps now, new pumps, over to ziconotide. And learning how to dose ziconotide, I've been very successful. Very few of those people ever come off it. So my question for you is, what's the role of ziconotide in cancer pain? Since there's no opioid immunosuppression, if you will, if you believe that occurs with what said earlier by Amit. So what's that role? So that's question number one. And to whoever wants to take that from Anjem and Dawood.
We've used a lot of ziconotide in our cancer patients. As a calcium channel blocker, it's another mechanism of action. And these patients usually have been on opioids long term, and they've been on fentanyl patches and oxycodone on top of that. So their opioid receptors are overloaded. So you're introducing something that through another mechanism of action through the calcium channel that actually helps with their pain, and not adding something that attacks immune receptor. So these patients have done very well. I think that there's a huge role in it. We've certainly seen benefit, and I'd like to see what Dawood has to say.
Yeah, I mean, I think it's an excellent drug when it works well in the right patient. I think, for me, it works the best when there's a higher component of neuropathic pain. Typically, our cancer patients have mixed pain, so most of our patients that we do put pumps in for cancer do require some sort of dose of opioid. If you can get a patient on a stable pain trajectory, I think it's a really good option for those patients. It is opioid sparing. The one issue that you will probably struggle with ziconotide is those of us that use it. It really takes a patient that you can be very patient with. Slow titration is really the only way to do it. Sometimes we will find with our cancer patients, when they have these pain spikes or their disease becomes more aggressive, they need more aggressive titration. And I think with the narrow therapeutic window of ziconotide, that could cause some issues for a lot of our patients. But I still think it's a good drug when patients with stable disease and largely neuropathic pain.
So we have 10 minutes left to be on time. And what I'd like to do is have Krishnan ask a question. We're going to start with you two, and then we're going to go to the other 4 panelists one at a time. We're going to ask you an important question that everyone on this webinar will take home with them tonight. So Krishnan, you can start with these 2 and I'll do the next 2. So ask far away for an important question.
All right. So on that note of being cerebral, one of our panelists actually asked this question. Is there differences in the terms of delivery, PO versus intrathecal in terms of immunosuppression? And does that change your algorithm in terms of considering pump earlier than later in pre and post COVID?
Andrew, you want to take that one?
So in terms of immunosuppression, I think that, PO versus intrathecal, certainly I believe with PO, you're going to get more immunosuppression than you would with intrathecal. With our intrathecal doses, we're, relatively low dose and getting adequate pain relief with low doses of intrathecal therapy. So I think that leads to less immunosuppression. These patients have certainly done very well with that. What was the second part of that question?
That's a perfect answer on Jim. that was it. But you're right. I mean, I think you look at some of Tony Yaksh's literature, there's some suggestions that obviously intrathecal versus epidural, there is less immunosuppression, arguably because you're putting it into a more closed system than something systemic through first pass effect or PO. So yeah. I think it's reasonable to consider that. I guess it's just a question of, from both of your experts in terms of pump therapy, does that change your algorithm? And it sounds that may be of consideration depending on how long this goes.
That part, I think you're thinking about, immunosuppression in that patient population is such a small portion. The bigger thing that we see is that the toxicity and the side effects. That's immunosuppression might be this much, but if a patient can't, have a bowel movement or go to their chemotherapy because their pain's uncontrolled, that's really a day-to-day thing. So that plays a bigger role of me going for the intrathecal therapy versus oral versus intrathecal.
Gentlemen, great
Can I just
answers.
answer one point real quick?
Yeah.
Just don't forget that pain also is immunosuppressive. So not treating pain is important. And we do have data that, we did a few studies, early pilot studies, Dr. Baig and I at Memorial, talking about converting patients to intrathecal drug delivery, converting to hydromorphone and testing their natural killer cell cytotoxicity and lymphoproliferative cells. And we found data that was very nebulous. So we don't know if the opioid is causing the immunosuppression, or it's the pain, or there's other cancer-related issues, because cancers have their abilities of also diminishing the immune response as well, and there's a natural history of cancer. So it's a very complicated question beyond just the opioid. We tried to answer those things early on, but keep those things in mind when we're treating pain. That's also immunosuppressive, and we can use opioids to do that, to treat their pain. But most importantly, we have animal studies that really show that long-term use of fentanyl and morphine, that immunosuppressive effect reduces considerably. So it's a very acute effect from the opioid, and the chronic effect doesn't seem to exist.
I just want to add to what you just said. I agree with everything you said. In 2002, Peter Statz, myself, and Tom Smith and others published a study on cancer pain that led to his first level 1 cancer pain study with pumps, and it led to more widespread use. And what we found was people that had their pain well controlled had better nutritional status, had better weight balance, had less fatigue, and they tended to live longer. And in fact, one patient would have lived one more day. It would have been statistically significant, the survival, by having their pain reduced, and using oral intrathecal. Intrathecal was much better than oral. So great point. Can we get our other 3 panelists on for a final question? I think you guys make great points, and if we could get Jay and Himmat and Don on, that'd be great. So let me ask you this question, Jay. You've been teaching fellows for many years. I have a great young physician joining me in July. I hope she might be on here tonight, Dr. Engel. And I interviewed 3 young fellows in the last few days. So I'm going to hire a second person. And I don't think any of those folks have done a lot of pumps in their training. Should they learn to do pumps, or is there any need for everyone to be a pump specialist in this cancer pain world we live in?
Well, I think obviously, absolutely, in my mind, and the beauty of it is that the management piece can be learned pretty easily. It's not something you have to pick up in a fellowship. And actually, from a technical standpoint, pumps are not all that difficult to implant either. So if you haven't had great exposure to it, you were used to doing spinals, you were used to doing epidurals, many of us that were anesthesiology based. If you weren't, you probably did a couple spinals early on in your fellowship, maybe, so you just didn't intend to do it. But it's something that you can certainly pick up pretty easily. And I would encourage people to really not fear it. As Anjem said, it's really about managing the patient, and it's about setting up infrastructure. And once you do that, they are the easiest group of patients to manage in your whole practice.
Very good.
I second that. I 100% second that. I think pump management is a dying art, and I think cancer pain management by itself is a very humbling experience. And if you have this in your armamentarium to offer cancer patients, you can improve their quality of life significantly. I still remember my own experience in my fellowship. I actually did 1 pump in my entire fellowship. We were not a heavy pump fellowship program. And over the years, we have reached a stage where we do the maximum number of pumps in our region. So I think it's really important to have that passion and then groom that passion and offer the treatment options and these therapies to our fellows so that they can start incorporating these therapies without any fear of them into their practice.
You bring up a great point about the fellows, and Don, we're going to give you the last question of the night. So if I came to you and I gave you a shocking, and I said to you, Dr. Sparks, I have a shocking piece of information. Let's assume that Dr. Grada and I are doing a survey, which we may or may not be doing a survey, but let's say we're doing a survey. And in that survey, and we might be doing a survey right now. We haven't published it yet, so we can't tell you. But let's say we're doing a survey and we find that the number of doctors who've been out of practice 10 years or more do 95% of the pumps, and that people less than 5 years do almost no pumps. That would tell me that we have a real crisis of teaching young people how to do intrathecal therapies and how to manage them. What would you recommend to the field, the people on this call tonight? What should we do to inspire young people that pumps are important, and what does that look like after fellowship to train people?
Well, I think that it's a great question, Dr. Deere, thank you. But I think that in this whole crisis that we're in, the world crisis we're dealing with now with COVID-19, right? Like, everybody's living in a state of fear. And if we look at pump therapy and just the information you gave about greater than 10 years versus not greater than 10 years, I think it has to do with a lot of fear-based information. Pumps can, cause problems. Pumps can overdose. You can have pocket fills. Like, people are living in a fear-based system as physicians. And maybe it's because they didn't do enough in fellowship. Maybe it's because they're not comfortable. Maybe it's because they think it's too much hassle. But overall, when pumps are used and when they're used correctly, they can provide so much good and so much help to not only cancer patients, but the chronic pain patient that you don't want to keep giving pills. The patients that need the Zinotide or whatever medications for CRPS that help them to have a better quality of life, and that's like our whole purpose as pain physicians. So I think it's to help them eliminate fear.
Oh, great.
Yeah.
I love that. I never thought of it that way. Dr. Chakravarthy, you get the final point, then I'm going to talk about the
Yeah,
next one.
I think to Dr. Bucks's idea of center of excellence, I think there's so much emphasis. I think Tim puts it beautifully. It's training is in what you see and experience, the mentor component. So, I think you guys all been tasked with probably me or Tim asking you at some point to do more potential society training for new fellows. I mean, this is a great opportunity to reach out and train those folks. And I think mentoring that is a critical linchpin to that. So I think it's very inspirational. I think you guys have all, I'm sure for a lot of the fellows today, it's really rethinking about how important pump therapy is in cancer pain.
So yeah, it's a great
I'll leave it to you,
point. I
Tim.
love that. So a couple last points. We do have something called Poster to Podium, which is a mentoring program that Erica Peterson is leading along with Hemant and others. And I think it's going to be an amazing program to help young people get to be impactful. Secondly, you see on the screen a webinar that we'll be having on May 21st. It's CME accredited on intradiscal therapies. And I think intradiscal biologics may or may not be the next thing. And we have a great faculty, Michael DePalma, who's a world-renowned expert in discogenic pain, Cass Delphon, Doug Beal, and Tim Davis, and Jackie Weissman, all going to talk about intradiscal therapies. And then we have the ASPN meeting in September. And right now, I do believe we're going to be there. And I believe they're going to be there. Many of us will be so happy to see each other. And we'll be doing all the precautions, but I think we'll see each other. And there will be a course. It's a hands-on course. And many of the faculty on this call will be teaching that course. And it's going to really teach those fellows who didn't get the full fellowship training. You may not have gotten all the exposure you wanted in your training because of the COVID situation. It'll give you a chance to work with some of these fine people on this call tonight and in our society to help you learn more about those therapies, and not just pumps, but also stimulation, DRG, spinal spacers, SI fusion, all those things that we see are the newest innovations. So I want to invite you to that. With that, thank you so much for tuning in tonight. Wishing everyone safety, the blessings of God, and good health. So thank you all for coming. As the faculty tonight, you were awesome, and thank you all so much.
Fantastic.
Good night.
Thank you. Thanks, Krishnan.